unable to join. Now, I guess the question is why. All right, this does happen sometimes. Let me send another one and just see. It may be that we have the an old version of Instagram. You're there. You're alive. I can see you. All is well in the world. Sorry. Excellent. That is good to hear, because sometimes these things happen. You have to go in and out a couple of times, and sometimes you have to very quickly reinstall the Instagram, which is eternally frustrating, but you are here and that is all that matters. So allow me to reintroduce you to the world. This is your first Instagram Live. You're the second person I've had today on a first Instagram Live. So I'll try not to make this too painful for you. This is Professor Zoe Winters, who is a consultant breast surgeon and heads up the London Breast Health Clinic here in Chelsea. And we are going to run through all these nasty, difficult things that surround breast cancer. So there is a lot to get through. So let's get into it. What do we know about breast cancer? How common is it? Because this is the perception is that everybody gets it, and there's an epidemic of breast cancer. Is this true? How many people do really get it?
So I'm sure a lot of the women know this, Fiona, because I can imagine they're quite a well-informed group. So I'm sure most women have heard that in the Western world it's about 1 in 8 women, and of course we're talking about a population effect. And there's some, at the moment we use the term sporadic or spontaneous, but we never really understood the functionality of those population genes. And so some of the things, and we can come back to this, that I offer women who are 40 plus years of age in clinic is a new test that the French have developed. And this is a test that actually evaluates multiple functional changes in a big gene data set. So
that's that, because we'll really get ahead of ourselves. But so we've got 1 in 8. Have those figures remained relatively stable, or are we seeing an increase?
No, I think, I'm not an epidemiologist, but to my mind, it's sitting at about 1 in 7, 1 in 8. Clearly that could change. That is definitely different in other parts of the world, and that's why we say the Western world. But in that context, if you have other epidemiological factors, for example, if you're in Scandinavia and you eat lots of dairy products and animal fats, you may still see that there are differentials in those groups. And then if you take, for example, Japan, or in the East where they eat lots of raw fish, etc., you'll get a preponderance of gastric and esophageal cancer, and therefore the breast goes down. So this is a complex interplay, and that's a Nobel Prize. We talk about various things and we put a lot of emphasis on, but it's cumulative effects, and we still don't understand the impact of environmental factors on that background population genetic machinery.
Excellent. And what do we then know about the risk factors? What do we know about the risk factors?
Well, once again, well bandied around, we're talking about postmenopausal body fat, and that's because in postmenopausal women, the majority of their estrogen comes from their body fat, their liver and their muscle, and of course fat is a source of estrogen by virtue of an enzyme called aromatase. And that is one of the drugs that women may have heard of, aromatase inhibitors, that we use in postmenopausal women. And that's effectively to turn off that production of estrogen, albeit it's much lower. So we're talking about body fat. Number 2, diet is important. I don't have an in-depth knowledge of nutrition, but the concept of animal fats, highly processed foods, who knows? We talk about estrogenization of lots of things, but have I really studied that data? You would have to speak to epidemiologists in Oxford that are doing a lot of these associated studies. When I used to teach medical students, we used to say alcohol wasn't a big deal. It was kind of partly on the table, and we said, okay, moderate risk is probably fine. If you drank lots, that's a real problem. But now we've probably lowered that threshold of just giving that advice. And that's not to say that the odd glass of wine, as the French do, is not a problem, but it's everything in moderation. So, excessive alcohol as you're older, high body fat, but that said, I diagnose cancer in women who is as thin as a stick. It's across the spectrum, so you can see that it's not as simple as that. And I probably don't want to venture too much into other things, but comorbidities such as diabetes, if you are diabetic, potentially not only do you potentially have a higher abdominal obesity or adiposity, but also in the lab, when we have very high glucose concentrations for cells in a culture dish, we actually see that chemotherapy cytotoxic effects are less active. So, we never used to talk about diabetes, but it's there. We haven't, there are studies looking at diabetic oral glycemic control with metformin. So there's studies kind of looking at the role of certain anti-diabetic treatments on breast cancer. I can't about the metformin trial, but that's still in there.
Age is another one, isn't it? So, I mean, it seems to be, it often affects people who are older, the older generation as well.
Trajectory of age. Clearly, the trajectory of the curve is from 40 years of age, a steep curve up to about 65, 70. So proportionately, we're detecting more cancers. Then the curve flattens out, but you're still at the highest point of the curve, albeit it's plateaued out. So as we say, follow the European guidelines and don't stop mammograms at 70 years of age. So we do need to talk about what the NHS does and the perhaps more ahead of the curve approaches in other parts of the world and potentially in the private sector.
Yeah, because we're living longer, aren't we? And I think I was looking at the breast cancer rates today, and they were saying in the over the age of 90, it's really very high. So if you're not going regularly after the NHS, if you're not asking your GP for regular checks as you get older, you could really be putting yourself in danger, actually, couldn't you?
Well, I mean, older cancers tend to be less aggressive. And, recently colleagues have published something called the age gap study. And this is always a dilemma. When do we come in with gold standard surgery, which is always going to be better than primary and what we call endocrine treatment, where we're giving someone a tablet to block those estrogen and progesterone pathways. But it probably should go until about mid-70s. And if you fit up into your 80s, go with your primary surgery. Don't stop your mammograms. You don't stop MOT in your car. And effectively, we can pick up a cancer, we can manage it. And in some cases, if life expectancy is determined by your age, i.e. if it's 5 years, we can put you on a tablet that can sustain you well. Is it the gold standard? No, but in that context, it probably is absolutely fine.
You mentioned estrogen in there as being a risk factor, and of course this is the one thing that worries people with menopause, but we'll get to HRT later. But when you say estrogen in that, what exactly are you talking about? Are you talking about a lifetime exposure to estrogen, and what exactly does that mean?
No, I don't think we have absolute clarity on that. What is a lifetime exposure? No one's defined. If I think about it, because we're interested in measuring, like a big genes data set, we're interested in understanding why 1 in 8 women get breast cancer. We don't really know that. We know that some environmental factors have their small contribution and therefore it's additive, but we don't really understand the impact of one woman's lifetime exposure to another. But if you think about it, a lot of women are on some form of estrogen and progesterone. They could be on the pill. They could have an intrauterine device. That's neither a bad, but potentially that is a different context to what women many years ago had. But there are many other factors. I think it's a lot more complicated than that. I mean, the majority of breast cancers are going to fall into an estrogen and progesterone receptor positive subtype. But, we know obviously there will be 15% who are triple negative, and then there are 5 to 10% that express the HER2 gene, which is part of what we call an epidermal growth factor pathway. So I don't want to oversimplify this, but we know from, I suppose, historical data that the longer you have uninterrupted stimulation of breast duct epithelium by estrogen and progesterone, we know those are permissive factors. We know they
are periods early until you finish your periods, and areas of being how many pregnancies you have, those sorts of things.
So those things are potentially important, but there's other things too. because there will be women who've had 4 children who get cancer. There will be women who've never had children that don't get cancer. So I don't want to oversimplify. It's about an awareness. And I think in the context of HRT, I'm a huge protagonist, but it's once again, how can we measure the impact? How can we make it safer?
True. You mentioned different types of breast cancer. So let's run through that, because that's another perception too. It's sort of like, oh my God, it's breast cancer. There's just one type of breast cancer and there's only one outcome. That is not necessarily the case, is it? There are many different types with many different outcomes.
Yeah. So, you know, the majority of breast cancers are ductal. We know that the cells lining the breast ducts are called the duct epithelial cells. So the more breast duct tissue you have, i.e. the higher ratio of breast duct tissue to fat, that puts you at a 4 to 6-fold higher risk of breast cancer. And it's not complicated, it's just that you've got more target tissue. So women who have dense breasts, we factor into a breast cancer risk score. And we'll come back to screening later. So we know the ducts are important, the terminal duct lobular units. You can look at a cartoon on Google, you know, so there's genetics going on. So there's genetics in every cancer and there's functional changes that occur. But if we talk about the simple readout that we look at, you know, we look at a multidisciplinary meeting, it's the type of cancer, so it's a ductal cancer, okay? That's something that has a typical pathological appearance. You get lobular cancers in about 20 to 30%. They're slightly different, they're a little bit more translucent. The underlying genetics is going to be different. They have less cohesiveness. They like a sort of a jellyfish. They can send out little single file cells called an Indian file pattern, like girls walking in crocodile pattern to school. And so therefore you can appreciate some aspect on a mammogram, but you may even underestimate them on mammogram. So mammography, once again, is contextual, and it needs to be supplemented by ultrasound in the context of dense breasts or a lump. So those are the common types. And then in the little old ladies, they could get terribly low-risk cancers. You know, it's a very different scenario. So there you have a very prolonged estrogen environment, but now these are women getting a cancer right towards the latter aspect of their postmenopause. So why does that happen? These are probably cancers that took 20 or 30 years to manifest. So you're getting some cancers, because remember, we don't measure how fast cancers are growing. We don't have an analysis of that. We use a little snapshot window test where we stain cells and we look at what we call a proliferation index. And that's something called Key 67. So we can get some kind of snapshot or window. It's giving us a steer. But then, of course, we do gene assays on cancers. So remember, everything ultimately will come down to mapping the cancer genome in breast cancers. And that will be the future. That tells us why some cancers spread, why some cancers are primarily estrogen-driven, others are not. But in principle, remember that even although a triple negative cancer does not express estrogen or progesterone or even HER2, we've got no real trigger. We're using other ways of treating those. They could still be promoted by estrogen. So it's oversimplification to say just because you have a triple negative cancer, you could safely give that breast cancer patient hormone replacement therapy. And there's a very good paper to support that.
So just so everybody knows what we're talking about here, we're talking about in those cancers themselves, the tumours have receptors that will either allow estrogen in, progesterone,
yes,
and different types of hormones. So if you're negative, it's not letting those hormones in.
I'd say that. That is oversimplification. Even although you don't express the standard receptors of estrogen and progesterone, and the usual receptor we measure is called estrogen receptor alpha, there are other what we call paracrine. There are other estrogenic permissive pathways that could still allow estrogen to promote. Because remember, when you start off, we call it a stem cell, and whatever the triggers are that cause that cancer to become estrogen positive versus triple negative, we do not understand. But it's still occurring in an estrogen permissive environment.
Right, I'm with you. Okie dokie. Now, before we get there, let's also have a look then at the, you mentioned mammograms there as one way of detecting cancer.
Yes.
And now a lot of people are fearful of mammograms, not just because of the pain, but because they think that they're going to be carcinogenic themselves. Should they be worried?
No, I mean, if we take standards that are occurring, and this is not to say that the US is the perfect mirror image, because we know it's a very commercially driven system, but we also have to look at our European partners, Scandinavia, Italy, France, Germany. Now, colleagues watching this and friends and so forth are probably aware that mammograms are offered in other countries from 40 years of age. And in fact, Stephen Duffy, who's from Queen's Medical School, Barts, has actually showed in a study called, it's a randomized trial, that means you've got a good control going on, that mammograms in women who are 40 plus years of age can detect at least 20% of cancers, and therefore there is merit in this. The studies were predicated on, because a study design needs to have an event rate, it was predicated on mammogramming women every year. Now, what we mustn't presume is that all women in their 40s are at the same risk. So not all women in their 40s are high risk. Not all women in their 50s are high risk. So the future is about looking at these population genes and determining, with other risk factors, density, family, number of biopsies, etc., not interestingly, not so much body fat and other things. The French have developed this, but basically it allows us to determine your personal breast cancer risk at 5 years. And that's super important, because it then means, I would say to women who are 40 plus, contingent on their own biology, what is their big gene data telling us? What are these population changes telling us? I would say it would be quite fine to mammogram you 2 yearly. But because your breast tissue is dense, in other words, we classify that as a CD density versus fatty A, we're going to add bilateral synchronous ultrasound. And I say that to women on a daily basis in clinic. Now, the NHS will mammogram you from 50 to 70. They've elected that pragmatically. Remember, population genes weren't around. They hadn't done the Age Extend trial. And by the way, the Age Extend trial is looking at women who are 40 plus up to 50, and then from 70 up to 76. But, you're still quite perky after, at 75, 76, and it'll shift. So there will be an overlay of women choosing that, because women are far better informed. As they're better informed about HRT, they're better informed about screening. So the concept in the NHS is rationalization. They didn't intend it, but in a sense, it is like that. They're presuming that everybody who has a mammogram every 3 years, that will suffice. They are suggesting that everyone 50 to 70 is limited risk. And in fact, not everyone from 50 to 70 is limited risk. So in the context of Mammorisk, you would then individualize what that population risk is, and you would say, okay, we're going to continue mammography 2 yearly. So what I say in the absence of Mammorisk, because it's not ready for prime time yet, we've brought it to the Chelsea outpatients from Paris, is to say, let's pragmatically elect to mammogram you 2 yearly. And that tends to shake down as the average thing. If we've got the high risk, then that's a very different scenario, and we follow the high risk surveillance. And those are women who have either had mantle radiotherapy for Hodgkin's, or they've got a moderate penetrance gene. We do a lot of genetic testing at this point.
And when you're saying, is that the BRCA1 and the BRCA2 genes that you're looking at?
So, I love this question because I love genetics. I work very closely with Angela George, who's an oncogeneticist at the Marsden. And the BRCA1 and BRCA2, Angelina Jolie did an amazing job. And I remember being called up in San Antonio when I was at a meeting at 2 o'clock in the morning, because she'd just come out with that. And I don't think I provided a very coherent answer. But the bottom line is, most people have heard of BRCA1, BRCA2. These are the DNA repair genes. Bearing in mind that these very high-risk genes have made a major impact, but they are responsible for only 5 to 10% of all breast cancers. That said, about 5 years ago, colleagues have now identified something called PALB2. So we must never just segregate that we're going to look at only maybe 3 genes, BRCA1, BRCA2, and PALB2. We look at what we call syndromic associations. So we look for cancers of the thyroid. We may look at gastric, colonic. And you can get a link between lots of colon cancer and breast in something called Lynch syndrome. You can get links between thyroid and breast in something called Cowden syndrome. If you've got brain cancer or breast cancer at a very young age and other cancers at a very young age, you could be dealing with what we call live Framini. So we can test up to 9 high-risk genes. In a panel called In Vitae, we could test up to 30 genes, or we can select 3 genes. And that's why I want a scientist involved. I want Angela to be able to think about those syndromic links. And interestingly, we've had women from the NHS who have been told they don't have a high-risk gene mutation. But the point is, if you've had testing maybe more than 5 years ago, you should be retested, because what we've discovered now are different alleles, what we call, don't ask me all the stuff, but different parts of the functional alleles that undergo change, or bigger parts of the whole gene that undergo change. So
the point is, even if you have the gene, it doesn't necessarily mean that it's set in stone that you are actually going to develop a disease. Something goes wrong with it to trigger it off. Am I right, or is that insane?
What I'm trying to say is, you may have tested negative 10 years ago, but our knowledge now has extended our testing to a much more comprehensive level, and women may have been told they were BRCA1, BRCA2 negative, and yet they carry another high-risk gene called PALB2, or they carry another gene called CHEK2. Now, our knowledge of these is changing and is increasing, so the panel of high risk is only going to extend. But it's still, I want to make the point that the majority of cancers are about what's the functional impact on multiple population genes.
Yeah. So with this Mammorink that
Mammorisk.
Sorry, Mammorisk you're talking about, you're looking at a variety of things there. So you're looking at the breast density. You're taking a saliva test to look at the polymorphic nucleotide.
It's called SNP. So if you remember SNP, single nucleotide polymorphisms. Don't worry too much about that. What it is parts of the DNA bases get substituted and they're little genes adjacent. So if you take the machinery of the body is controlled by genes. They control everything. And what happens, what are the kind of functional changes in life that are driving these small little low-risk genes? And then you get multiple genes, you get a pyramidal effect. So you get a big gene data set. So you're testing something like 100 population genes and their functional changes.
And once you've got that picture then, and you wrap it in with the breast density and family history and those sorts of things, then what are you telling your patient once you've got the big picture in?
So basically what the Parisians have developed, you've got an online, they fill out a questionnaire. This is an AI-developed algorithm. And basically, like you would complete on a pad, it gives them a risk score. And effectively, I'm even happy to share what that is, and we follow European guidelines. And so you will either come out as in the population, high risk. If you're high risk, we will mammogram you annually. Now, here's the thing. Let's say you came out intermediate risk, and we would mammogram you 2 yearly, but you were a woman who started to have perimenopausal symptoms. Now, we're getting into the exciting crunch, which is absolutely your thing, Fiona, and all your team. And we refer to Harley Street Emporium. We use that link tremendously. Is that, let's say we take HRT, we might have to take combination HRT because we have an intact uterus. I would like to ask the Parisians whether we then, at 5 years down the line, repeat the Mammorisk to see the impact of the HRT. Or let's say we want to extend our HRT longer, which many women would want to do because they feel so great on it. Once again, is there a case for extending and saying, let's repeat the Mammorisk? In other words, is the HRT slowly modulating some of those signals? You could argue that this is a modality that could, or that this is a test that we could use, but I haven't kind of asked the Parisians about, I haven't asked the scientists about this yet. It's kind of how I'm thinking in my head.
Okay, yeah, it's an interesting one, especially because the newer types of HRT now, the transdermal ones and things like that, especially the estrogen, appears to have lower risk than its predecessors. So, I mean, sort of things are changing. So it'd be interesting to see what the difference was later on. You have a question here from Menopause Health Doctor about testosterone replacement post-breast cancer and any risk of recurrence. Do we know much about testosterone and post-breast cancer?
And you know what? menopause health doctor, I'll go and look it up, and certainly happy to look at some papers. And, you know, some of the papers I've drawn on just prepping for this, just to kind of brief me again on the kind of content of what I discuss. I know, you know, you've mentioned Isaac Mayonde, and, you know, he's trying to find that safe approach. You know, let's say quite clearly that estrogen only HRT is a winner. But of course, that transdermal estrogen alone can only be used by women who don't have an intact uterus. We know that's the big winner, and we know that's the thing that's potentially, although even a recent paper in BMJ doesn't say it's overwhelming, that it could reduce Alzheimer's, dementia. Number two, we know it's great in osteoporosis. Yes, we can treat bone health in other ways. And certainly as a transdermal, it doesn't increase thrombosis, it doesn't increase cardiovascular events, I don't think, Fiona. It's really the oral estrogens that are associated with the thrombotic events. So there is such a thing as safe estrogen. And the bottom line is, if you take estrogen only, you probably live longer than someone who never takes estrogen. And in fact, both you know all the stuff, but the big cohort study, the Women's Health Initiative, said, okay, it drives down breast cancer risk 23%. And that's at 10 years, and it continues to do that at 13 years. And then other Oxford, and I'm happy to share these papers, other Oxford cohort studies on quite large numbers of women, 98,000, 450 controls, 98,000 breast cancer patients. We've got a very good rap for estrogen only, and even if you take it recently, you don't increase your risk. So you can literally take estrogen only long term. The problem is, what progesterone do you use? Try not to use an oral progesterone. So Fiona, I'll let you take over.
Yes, it's interesting to see what happens actually with the as you know, as Utrogestin rates increase over a period of time, how things may change as we get to know more about that. All right, so before I get to HRT and breast cancer, just let me go back a little bit to, so, all right, so I've got my risk score. What do I do with that then? So you're going to say, okay, your risk is higher, medium or lower. Come in and have more mammograms or more checks every so often. Is it, I guess my main, put it this way, early onset Alzheimer's runs in my family. People have said to me, why don't you go and get the gene test? And I kind of think, actually, you know what? I don't want to know whether or not I've got that gene, because, you know, I know what lifestyle things are good for my brain. If I know I have that gene, every time I walk into the kitchen and forget why I'm in there, it's going to be a double whammy for me. So I would actually rather not know. So if by giving me a risk, it tells me that I've got a higher risk than somebody else, am I going to be just worrying myself more than I really need to?
I always say, like, if you know where the break is, you don't hit the wall. The concept is be ahead of the curve. We're in the 21st century. You're a 21st century woman. You're priming yourself. You're priming yourself with your arrows. You're ready to go. You're ready to hit the target. Knowledge is power. You know, being blind and trying to cover up is not really a way to get ahead of the curve. So if you catch the wave at the right time, that's exactly what you want to do. This is not about saying you're like at an Angelina Jolie risk. We're not predicting this is a 40 to 80% lifetime risk to 80 years of age. We're saying you are in the population. This is going on in your background machinery. What are the factors? That's a Nobel Prize. You know, all the kind of this stuff we've said. And if you look at the tables, we did this in medical school. You've got it increases the relative risk and it goes up and up. And I never really understood that. But it's all like a pyramidal effect. It's quite hard to determine. Breast density is a big, big thing these days. So I think women, when they get a mammogram report, every report, and we share every report with every patient electronically, they get the real thing and they see what their breast density score is. That's a darn good start. But we're talking about just regulating mammography in a personalized way. And there's massive studies going on, randomized trials in both the States and in Europe. And the state study is called Wisdom, Women Selecting Mammograms Based on Risk. And they're using a Mammorisk type algorithm. That said, Mammorisk has been validated in Caucasian women, and they're still developing that validation set for African American, Middle Eastern. We don't know a lot about Middle Eastern genetics because not a lot of Middle Eastern women are genetically tested. So we know there's a lack of knowledge there. So that's just a point to make, that at the moment there's a slight caveat with that. So I don't think it's a fear factor. I think it's opening that door and saying, you MOT your car and it's a lump of metal, and we do that just because Boris says we should. This is an opportunity to, I guess, arm yourself. But it is a personal choice. Personally, I'd like to know every gene I have, because then you'll start, anti-dementia medication isn't brilliant, though, I don't think, Fiona.
Well, this is my next, actually, if I know then that I've got those particular genes, does that help me then, apart from making lifestyle choices? Are we at the stage where it will also help with treatment choices should I develop the cancer? Will they be more personalised now, or are we still waiting for that to happen?
No, that we haven't quite got there, because even though we can test, this risk is about, a high risk will fall at more than 1.66% in 5 years, but it's under 6%. And you can see we're talking population risk here. This is not like BRCA Angelina Jolie risk, and this is the majority of women. And I don't know what cancers they're going to develop. Eventually, these tests will tell us whether you're going to develop an estrogen positive cancer or a triple negative cancer. They could tell us this. So all it does is tell me I should mammogram myself annually instead of 2 yearly, and that I'm not just going to follow the NHS program and get what we call an interval cancer. And remember, I said, because the NHS program presumes everyone is limited risk. So
yeah. Question here for you: do we have an increased? I mean, if you I can't even speak anymore. If you have an increased genetic risk of developing breast cancer, would combined HRT increase this risk further?
Yeah, that's a good question. I mean, let's talk about, if you talk about an increased genetic risk, let's talk about BRCA1 and BRCA2. If you're dealing with those risks, then there are clear risk prevention studies, and HRT becomes a much more, this is a very difficult discussion. Remember, when we find a high-risk gene mutation, this is a gene that has come directly through the chromosomal inheritance. Of course, everything we inherit is genetic, but these are the genes that are specifically linked to a parental X or Y chromosome, or XX and so forth, because the genes are transmitted through the male side as well. Some of them are very dominant and will appear in each generation, others are moderate. So we're talking very high risk. Now, in that context, we're starting to use MRIs. If you carry a BRCA1 like Angelina Jolie, you're using an MRI on an annual basis from 25 years of age. You're using ultrasound. And you're not, then in your mid-30s, you're discussing risk-reducing surgery, because that normalizes your risk to that of the general population. And remember, these genes can affect other target organs, and so these women are offered oophorectomy. So the concept of HRT now, it's a very good question, because now if I've had an oophorectomy, do I want to then give back estrogen? In principle, the oophorectomy is designed to lower estrogen. So I would be very cautious. And I know I'm hesitating here because, in a sense, we've removed 90% of the breast tissue. There could still be small residual tissue. So I think we would probably be using alternatives for symptoms of surgery, menopause, and we might be using topical vaginal estrogen, which I worry about because, as Fiona will probably correct me, there's a very low systemic absorption. So, what can we use there? Fiona, do you have a thought about that?
Well, I mean, most people, and I think there was a study that came out recently that was saying that they thought that it was a pretty safe alternative because it is just such a low systemic absorption. I guess from what I gather from most of the doctors that do HRT, is in the end it comes down, I think, to the quality of life. And if you're really, really suffering, even though if your life has been made a misery with anxiety and vaginal symptoms where you can't sit, your relationships are falling apart because you can't have sex, do you take a risk benefit judgment, an informed choice, and then, make sure that you're getting yourself regularly screened in case something does come back, but at least have some form of quality of life? Or do you just go, no, I'll just put...
I don't think it's a blanket answer, because there's such a patient I heard about who has got a managed approach to HRT with a menopause specialist. She's in the context, I suppose, if one's able to take transdermal estrogen, that's possibly the way to go. But then that is predicated on possibly a Mirena coil plus a transdermal estrogen. So the concept of selecting the best of the bunch is really where we should be at this point in time. So it's not a blanket no, but it's a cautionary approach. I mean, there are women who have had skin-sparing mastectomy and get a recurrence after cancer. So we're talking about women who've never had a cancer. You could still develop a little cancer if there's retained breast duct tissue. So there's that constant awareness, but it's a balanced decision. As you say, a prohibitive quality of life is also not a great scenario. So you are arbitrating. It's an arbitration, really.
Yeah.
Clearing a middle path.
Yeah, and not your usual menopause is pointing out here that a whole year's worth of local vaginal estrogen is the equivalent to one dose of systemic HIV. I'm not sure that the maths is exactly right on that one, but it's yes, I think they normally say that it's
read that topical vaginal estrogen. Of course, we would use that reasonably happily in women who are on tamoxifen, and tamoxifen is the tablet that still allows background estrogen, because it's blocking the receptor, so it blocks the estrogen from acting on the nucleus of the breast cancer cell, and we would be okay using a topical vaginal estrogen if someone's on tamoxifen. But if someone is on the aromatase inhibitors, that means they're postmenopausal, and clearly we make them feel worse. We're not happy with topical vaginal estrogen. So the oncologist is still quite reticent, because in a sense, it's totally counterintuitive. However, if the menopause specialists say to us, look, that is really topical, that is it's a local Enveron. It's not, there's such a small amount that's getting systemically absorbed. Could we push for that? I still know my oncology colleagues, which was very highly regarded at the Marsden, was still reticent about that. But, I think it is a slightly moving target. We're much more conscious of survivorship in these women, and these women are surviving extremely well. And so we're happy to flip drugs when we need to.
Yeah.
Back to tamoxifen and give them topical vaginal estrogen.
Yeah, because the quality of life is important. I mean, as you do breast conserving surgery, and you're also sort of, is it pedicle surgery, really trying to make sure that you've got great the least amount of invasive surgery to give the best sort of quality result afterwards. And I think there's often sometimes a thought with many oncologists, which is understandable. It's sort of like, my God, you had breast cancer, you should be goddamn happy that you're alive, put up with the other things because you're alive. But in the end, if your life is so miserable, then perhaps you actually have to have a trade-off on various things. And if it means being able to actually have sex with your husband again so your relationship stays in order, then you may decide that that's a risk that you really want to take.
And that's why it's so important for us. We work with teams of psychologists, psychiatrists. I think we could do a lot more with linking in with nutritionists, exercise coaches. We talk a lot about exercise, but of course, it's a bit of a double-edged sword. So we are inducing premature menopause in young women, and we're doing that often because their cancers are high. So we've got those issues to deal with, so we have to be super supportive. So I know that what oncology colleagues are doing, for example, with the vasomotor symptoms, they're electing to use alternative drugs, allopurinol or pregabalin, and some of them are not that, don't make you feel that great. But that's the route they will be taking, because if we are trying to, let's say, a young woman with a high-risk cancer, it could be estrogen receptor positive, and it also carries the really rapid growth gene called HER2 positive. those are very risky cancers. They are high risk, but we have fantastic drugs that can block HER2. But those drugs, we will also say, when we give them the endocrine treatment to block estrogen, and they could be expressing progesterone as well, we will often give them something to suppress their ovaries. And so we are truly making them medically postmenopausal, and they could be in their mid-40s. So that's a difficult one, but we're doing that because their risk of recurrence is highest.
So it depends on the type of cancer that the person's got and how receptive it is, and where they are in their stage of life. And it's a lot of things to think about.
Yes, I would say clearly we haven't quite got onto HRT and breast cancer. The general consensus is that in the presence of receptors, if you look, there's a cohort study from, it's sort of like a cross-sectional study from New South Wales. It's called the CLEAR study. And basically, it's not super big in terms of numbers, but if they looked at women who had developed breast cancer, there were about 399 against controls. Women who didn't have cancer, 342 or so. And there were women who had been on HRT versus never. And there was a definite association between HRT and estrogen and progesterone receptor positivity. So if you have a hormone receptor, whatever the mechanisms are that are producing an estrogen and progesterone receptor positive cancer, you can't say it's absolute cause, but there's an association. So it's a bit like saying this is the perfect nutrient for this plant. This is a permissive environment. So the concept of whether women on HRT will have a link to triple negative and HER2 breast cancers is poorly understood, and there's no clear evidence. But it is not true to say that it's safe to give estrogen in a triple negative breast cancer, because there are multiple alternative pathways that don't have to work through something called ER alpha, which is the estrogen receptor we measure. There can be other markers, such as estrogen receptor beta, that we don't measure, and an androgen receptor that estrogen will promote. And there can be default pathways that estrogen will promote, even although it's triple negative. And there's a superb paper on this.
Yeah. There's a question here. What's best to have, a mammogram or the ultrasound to detect breast cancer? And this is an important one, actually. I'm sorry, we go back. We digress a little bit on this one, but I just wanted to get it answered. Because, I've actually had a number of people say to me, well, you know what, I'm not going to have the mammogram. I'm only going to have the ultrasound. Is that a wise decision, and does it really matter which one you have?
Oh, so it's really age dependent. So the international guidelines are if you're 40 plus years of age, we get the best deal. We get the buy or cost effectiveness, because firstly, you're on the trajectory of the steep curve. Number two, if you take young women under 40, you've got the potential for very dense breast tissue. You have super levels of estrogen and progesterone. And if you have very dense breast tissue, that's the white component on an X-ray. And if you have lots of white on an X-ray, you have a snowstorm effect. So you lose mammographic sensitivity. So the concept is there's no absolute, there's no indication to do mammography under 40 unless you have a clinical suspicion or unless you see something on ultrasound, because there will be women in whom we diagnose breast cancer in their 30s. I have them, other colleagues have them. And interestingly, they may even present, particular patients can present in pregnancy. That's not common. It's about 20%. But it can be exceptionally difficult to even see the tumours on mammogram. And so we may feel a lump, we ultrasound it, it looks slightly suspicious. We may then mammogram, because we have to check whether there is microcalcification. So we might still do a mammogram, but it is not a screening, it is not a recognised international screening tool in women under 40 years of age. We would then use more MRI in women who have a problem, who are under 40. Mammography from 40 years of age, either annually or 2 yearly, that's patient choice, or Mammorisk when it's available at Chelsea, and that's a self-funded test, about £300. It's not in prime time yet, but should be very soon this summer. And effectively, I would then say, if you're in an intermediate category, you carry on to yearly indefinitely.
But you shouldn't just say, I'm only going to have an ultrasound.
No, because you will not. Firstly, Ultrasound does not take a picture of the whole breast. Ultrasound does not allow us to compare the breasts. It is operator dependent. It is only as good as the person holding the probe. If you have very large breasts, are you going to ultrasound every centimeter? No, you are not. You're also not going to pick up areas of increased microcalcification, which is basically an appearance on an X-ray of a salt and pepper effect. So you're not going to pick that up on an ultrasound. So that is misperception, not information. And the concept is if you're 40 plus and we're doing a mammogram, and as I said, just to iterate that point because I think it's important, is that if you're super dense CD, then you are going to have a bilateral synchronous ultrasound as part of your mammographic surveillance. That is the latest stuff. In America, they bash on about this all the time, and they're right to do it.
Fair enough. Let us move on to treatments. So, in terms of surgery, now you do a lot of this. This is your thing. We're either having mastectomy and having things off, or we're having sort of small amounts taken out. What do we know now about best practice and who is suitable for what?
I mean, I love this question because I think the big registries in Europe, whether it's the Scandinavians, the Danish, or the Norwegians, have actually shown we don't know exactly how to explain this, but when you case match, and that means you're matching age, you're matching tumor factors, numbers of factors, so we're looking at receptors, the grade, blah, blah, all the things that we are sort of using to steer some of our decision making, that really breast conservation gives you superior survival. And we don't know whether this is truly the additive effect of radiotherapy. Because why do we give radiotherapy? Because firstly, there's risk of recurrence is in the site of the cancer because there can be microscopic, what we call multifocality, and we won't even see that on an ultrasound or mammogram. So the concept is in the locale of the tumor, we will always give the most radiotherapy, and then we call it intensely modulated, then it extends out peripherally to lesser doses. So it's kind of a what we call a targeted approach. So in that context, virtually all the big registry studies, and these are like 25,000, 23,000 women, are showing real, better survival with breast conservation. That said, when we conserve, we need to get clear margins. That doesn't have to be massive. I won't go into too much detail, but it can be a millimeter away. It can be a tumor clear ink, as in the States. But
so when you're taking the tumour out, you're sort of gradually going wider and wider, checking the cells, making sure they're clear and all.
But what we do is that the margins that we allow for clearance microscopically have shrunk. So years ago, everything was radical. Now everything is what we call de-escalation. So we've got smaller and smaller, except remember our imaging is better and better. So we have very high quality mammography, we have 3D mammography, we have MRI, we have very good ultrasound. So we have highly skilled screening. So we map out better than we ever did. If there's DCIS, if we think there's something, we take targeted biopsies to map out the extent of what we need to remove. And it's basically simple proportions. If you've got a large breast that is permissive to a breast reduction, we can take out an area where we can put magnetic markers from one end. Let's say you have 4 centimeters or 5 centimeters. You can insert a little magnetic seed called a mag seed, and basically it's like putting in a little marker clip, and you can insert that into 2 disparate ends, and then you use a Centimag probe inserter, and you can determine exactly where you're going. So you're mapping it out with a bit of a sat nav that's dynamic, and you have a little probe that tells you what to do, and you then remodel the breast by doing a reduction. You can save the nipple. Sometimes you can't, but there is certainly a huge thrust towards breast conservation, but it's got to be good. There is no point creating a conservation with a bad cosmetic result, because then it wasn't the right decision. And therefore, we're also very open to immediate breast reconstruction. We do a lot of those in London, and we do a lot of abdominal flaps. So I won't go into that, but you can either reconstruct the breast with your lower abdomen, that's plastic surgery is working with you. We do the mastectomy, and the node side, the plastic surgeon does the microvascular. And that could be 4 to 6 hours. And then what I would also do is implants. We sit implants on top of the muscle. We save the skin. We save the nipple if it's safe. We always try to save it because it gives you a very good cosmetic result. And then we wrap implants in something that looks like a string vest. Basically, it's called an acellular dermal matrix. And you can wrap it around. And in a sense, it's an animal derma, so it comes from either pigs or cows. It's completely non-immunogenic. So it's very clever. I mean, it's been around about a good 10 years now. Very established in the field. And that means where we used to have an expander, then you had that for 6 months to try and get those beautiful results of getting the implant, getting mitosis. Now we can create a very good result by using something that helps us place the implant exactly where we need it.
And actually, why above the muscle and not below?
That's a really good question. We started off doing what we call subpectoral, lifting up that chest wall muscle, popping it, really putting it in that lower pole, and then putting the hammock of the ADM and sort of suturing it to the bottom and attaching it to the muscle. But there's prepectoral has been, putting it on top has been around forever. But the colleagues, I heard surgeons in Miami talk about this many years ago. You've got to have enough skin thickness, so that's the first point. If you are very thin, it's going to look like a pomegranate or an orange on the chest wall. Now, the point about putting it on the muscle is you have a good overlying tissue or skin thickness. Why damage the muscle? Because that pectoral muscle is still fulfilling a function. It's one of the many muscles that sort of works the shoulder muscle. So, you could get a slight, you get potentially, they say, more pain. And of course, you could get more bleeding. So surgery now is about finesse. It's about less is more. You may consider under the muscle, but I think most surgeons are sitting it on top, and then are doing fat filling if there is a sense of an implant effect or they want to bolster subcutaneous tissues.
Yeah, that would make sense. Now, coming back to the mammogram, a question here, and this is one that you hear all the time. Don't they say having a mammogram is the equivalent of taking a return flight to Australia in terms of radiation? This is one of the reasons why people say, I'm not going to have one. Is there any truth to that?
Well, people take a flight from London to New York. I have seen a paper which refers to that. There would be no doubt in my mind that the absolute benefits so far outweigh the risks. And remember, that's where we're talking about personalized mammography, having it based on your personal biology when relative to your risk. So the concept that you live in London, you're exposed to multiple radiation, we don't think anything of it.
In front of the screen as we speak.
Sorry?
In front of the screen as we speak.
Yes. So really, and I know there was a figure, and I don't know if I think what the figure is, you will mammogram 968 women, or it might be even more than that, and within that there will be 16 cancers. It is so imbalanced, from the perspective of saying that element negates it. It just doesn't make any sense. And nowhere in the world have they subscribed to that. So we don't do anything in a cavalier way, but the radiation, if you're in your 40s, doing an ultrasound is not analogous to a mammogram, and I would stand by that strongly.
Okie dokie. We have 1 minute left. And so let me just throw in this last question here that somebody else sent in before, because I think we've sort of randomly covered the others. Post-cancer mammograms, why do they stop after 5 years? Do they? I was surprised when I saw that question.
Yeah, they don't completely stop, but they then go to 2 yearly. So, I think this is where they've made another pragmatic decision. Remember, most cancer trials go to 5 years. That doesn't mean that's the perfect number. If you take a low-risk cancer, that cancer, potentially, if it does recur, could recur 20 years down the line. So there's a concept, there's a paper on this, whereby if we take potentially low-risk estrogen, progesterone receptor-positive cancers, potentially we would favor giving 10 years of tamoxifen, and that's because low-risk cancers recur 20 years down the line, 15 years down the line. Remember, cancers can grow extremely slowly, so you never stop mammography, but remember what the NHS can do is factored in. It is a system that cannot sustain everything, and therefore there is a commitment by some folk that elect to choose a system that's maybe more bespoke, but the NHS will mammogram you annually for 5 years and then 2 yearly for 10 years. So it's not that they shouldn't just stop at 5 years.
Brilliant. All right, it is 6 o'clock, so we need to go because otherwise it'll cut us off, and we won't be able to save this, and it will be lost. So thank you so much for that. Just quickly tell everybody where they can find you again.
No, hold on. Where can they find me?
They can find you at the London Breast Health Centre in Chelsea. Where else can they find you?
London Breast Health, and that's Kings Road, Chelsea. 1 Welbeck in Marylebone, and also New Victoria Hospital, Coombe Lane, West Kingston.
Brilliant. Look, thank you so much. I hope that wasn't unbelievably painful for your time, and I hope it won't be the last.
We didn't talk much about HRT, really.
Well, next time. It's such a big topic. All right, let me go because otherwise I run the risk of losing it. Thanks so much. And bye.